So we've got a room for 12:30 till 2, depending on what we have. I'm hoping we'll be through with session, but just stay tuned and I'll let you know what we're going to do. I have added a bill, as often happens, or a resolution to this time. I want to call Representative Bodie. And this is House Resolution 420. It's 422. Is it in our folders? Okay, it's House Resolution 446. And we have started out because of a death of a youngster named Johnny Talbert III. And she didn't know that she was going to get put on the spot with us. But his mother is here. Yes. Miss Talbert, can you stand up like that? Thank you for coming. And just know that this committee is a very caring committee, and that we are so sorry for your loss. And thank you for being active and trying to do something in his memory. So thank you very much for being with us today. Okay, thank you. We have House Resolution 446, and I will tell you that Mr. Talbert was going to come, but it's my understanding that this loss still so affects him that he didn't think that he could come and be with us today. But he is with us in spirit. Yes, and sent his better half, just teasing, of course, if he's listening, to come and be with us. Okay, so House Resolution 446 we had last year. It was went to rules. It was recommitted to us. And if you'll remember, this was started out as just heat stroke. And I'll let Representative Bodie go further than that.
Yes, thank you so much, Chair, for adding House Resolution 446. Basically, last year it did start out as just a heat stroke bill for youth sports and high school sports. But this committee, we were able to get together and through bipartisan efforts, create it where it also dealt with cardiac arrest and other sports-related injuries. And today we're presenting this bill in the memory of John Talbert III, who died at Welcome All Park as a 13-year-old or 12-year-old at the time, participating in youth sports. We also had a high school player from Burke County, Roderick Rod Williams, to die in Waynesboro, Georgia, from the same heat-related injuries. So what I'm asking here today to create a House study committee of 5 members to be appointed by the Speaker of the House to look into what we could do as a state to remedy this situation and to no longer have youth deaths through youth sports and high school sports. So I would be asking for a due pass today. This bill did pass out of this committee last year. It made it to rules, and we were asking for it to be passed again today.
Okay. Questions for the representative? Representative Reinders?
Yes, Madam Chair. Thanks to all my colleagues. I'm just looking at the last line, shall abolish December 1st, 2017.
Yes, I will be asking for a friendly amendment to make that December the 1st, 2018.
Is that the only?
Yes, that's the only thing.
Scrivener's error?
Yes.
Right.
Yes, sir.
Thank you, Madam Chair.
Okay. So, that change would be to have it on line 64, change it to 2018.
Yes, ma'am.
Okay. All right. Representative Hilton. Okay, thank you. But the Hawkeyes here, we got it, okay? Representative Lott.
Thank you,
Okay,
Representative Howell.
your light's on. Who is it? Oh, Representative Peacehold.
Representative Reinders also beat me to the punch. Representative, thank you for your hard work on this bill. We appreciate it.
Thank you so much, Mr. Representative.
Okay, I got these popping up. Who have we got? Representative Mitchell. Okay, when it's appropriate, let me get the questions answered. Who's this? Huh? Representative Howard. Or Jeepa?
I think Representative Mitchell beat me to it. I'll motion do pass.
Okay, well, speak up real loudly and we'll let you do the second.
Okay.
Okay, how's that? Okay, those are all the questions. All right, is anybody from the audience that wants to speak on the bill? No? Okay. All right. We have Ms. Talbert. Did you want to speak? Did you want to go up to the microphone? And Mr. Davis, you're going with her too? Okay. Just support.
I'm trying not to be emotional, sorry.
It's okay, you're among friends.
I'm just asking that you please pass this bill. Not only for my child, but for other kids out here as well. It could have been any other child, not just mine. I'm not just standing here for Jenny Tolbert. There's a lot of young kids that can have the same issue. So just think about it, please. And I want to thank you, Chairman Sharon, for even allowing me to come here today. It means a lot. Thank you.
You're welcome. As I said, this is a very caring committee. We care about patients and what happens to our young people across the street, across the state. As I told you, we passed out the concussion bill out of this committee and fought for it several years ago. So, and I think probably everybody on this committee is like me. I don't know of anybody that's lost a child on this committee, and I think probably most of us cannot imagine anything about the pain and what that's like. And I wish there were words that would make it easier for you, but as I said earlier, I understand. It doesn't, there aren't any words for that. Okay, if we have no other people that want to speak on the issue, Representative Mitchell.
Thank you, Madam Chair, and thank you too for your caring and your passion for these kinds of issues. I think this is one of the things that we will go down in history as one of the better things that we've done. And on that respect, I'd like to make a motion of due pass.
I have a motion to pass. Mr. Howard? Got a second. Any other discussion? Everyone in favor say aye. Aye. Anyone opposed, no. I think you have a unanimous vote. So, and I would ask the committee members as they see the chairman of rules, can you sort of put in a good word and ask that we get House Resolution 446 out of rules. Thank you very much. And if y'all need to leave, don't think you have to stay through this whole thing, because we may be here for a while. So,
Thank you so much, Madam Chair.
you're welcome. Thank you, Representative, for bringing it to our attention. Okay, here we go. All right. Let's do Senate Bill 202. What do we got? Which one's this? Okay. Okay. This is this one. We didn't have anything else to. Okay. This one's my bill, in essence, just with a different number. This is Senate Bill 202. It's LC 337424. As you know, during this time, things often travel on other bills because we've run into roadblocks on the other side. This is the one that we passed out of here. Didn't we pass it out of here? I've forgotten where all this, no, this passed out of aging. What it does is sets up and allows district attorneys across our state to set up in their jurisdictions working committees of the people who deal with elder abuse, like the police, of course the DA, with our APS workers that come, that do the inspections and go out and list complaints. And it clears up all of the interconnected problems of when they can share information and when they can't share information. It's sort of based on like what the child fatality groups are based on, and except that we are hoping that by having these groups across our state, that we will prevent fatalities among our elderly. And the example I used in that, if you'll remember, when we had the nurses, and it was on the television, who laughed and carried on and didn't help an elderly man as he was dying and begging for help. And the police in that jurisdiction were not sure if that was elder abuse or not. It was actually stated that they didn't know how to charge it, but they luckily did turn it over to the district attorney for their jurisdiction. So hopefully, like I say, this is not a mandate. Already in Augusta, I can tell you that they have set up a model to this and are doing a fantastic job. We are working and have sort of the same thing in Cobb County, and it's amazing. I have gone out to different places to help explain elder abuse, and we've invited the police, the district attorney, and these kind of people, and it's amazing what they share and what they didn't know because it's such a new area. And I would tell you that if any of you, as we go forth over the summer and the fall, one of the things that we've done is try to find a legislator to sponsor the lunch. And they come into your area and talk to people, and the turnout is very good. So if any of y'all would ever like to be one of those lunch sponsors, let me know, and I will try to get you to the people who organize this. It's amazing. You've got a young policeman down in Rome, not Rome, but Pizzo, where do you live? Columbus, who had questions, talked. They went down and did a great big meeting there. There was a huge turnout of people, and they are really taking names out there and trying to help the elderly. So this is basically, since this bill is held up, this is what this bill does. I'll be glad to answer further questions. Representative Pizzo.
Thank you, Madam Chair. Is it not true that this was House Bill 635 and it passed the House unanimously?
Yes, sir. Thank you for that. It did.
And I'll offer my services for food down in Columbus.
Thank you very much. I will
Be
let
glad
them know when they have another meeting. Thank you.
Certainly.
Would that be from?
You name the place. From Cheddar's.
Yeah.
Fazoli's. Representative Peak will be happy to help.
Do I have that offer for Macon also?
Absolutely.
Sure,
He's got a
absolutely. Good.
Fazoli's in
Okay, I'm getting
Columbus
all
coming
sorts of
up.
takers here. Okay, Representative Reiners.
Thank you, Madam Chair, and I think I co-sponsor this, and I don't know what happened in the Senate where they, or wherever they don't recognize, a good bill. But I just want to make sure that it wasn't tied up in anything, because I don't see anything there that makes this an unfunded mandate to locals, because I think if that rumor's out there, that it's not true. You may choose to do that, and who you invite, you may choose to do it. We just think it's a mechanism for education purposes to ensure that the elderly don't get abused. And I just think that kind of really fear-mongering in some areas probably isn't right. But there's not a funded mandate or unfunded mandate in this that locals have to do that. It's my
No, it's totally voluntary.
Right. Thank you.
But I think already, since Augusta and in Columbus and in our area, they're already recognizing how important this is, and they're sort of doing this on their own. But like so many things, we have rules about the sharing of information. So, like somebody that would come from the Adult Protection Services might not feel like they could share something, and this clarifies that sharing can go on, what is confidential and all. So it makes it clearer and puts people's minds at ease of what they can share and
I
discuss.
just heard a little chatter. We got to pay for this, and this is unfunded. I go, it's not. You
No.
need to read the bill. That's my
No,
point.
it's up to the district attorney. They can decide if they want to do it once a year, they can do it. I mean, the bills, I think, suggest 4 times a year, but they can do it
Right. Thank you.
at their discretion. Or if,
Or more.
or not at all if they think they don't need it. So, that's a question. Any other questions from the committee? None? Is there anybody that wants to speak on the bill?
Move to pass.
Okay, I've got a motion do pass and a second. Is there any other discussions from any of the committee members? Okay, everybody in the passage of the substitute to Senate Bill 202, say aye. Aye. Anyone opposed? No. Okay, thank you. Pass ones. Okay, which one's mine? Okay, 325. Okay. All right, let's call Senate Bill 325. You know, I was getting a little paranoid to thinking that only my bills were being held over in the Senate until I heard that Representative Dempsey and Representative Lott and a few others, and Representative Peaks, and, you know, and seems to be a lot of it, you know, sort of only one committee we seem to run into trouble with, or not one, there's one or two or three. But a lot of them seem to be a problem. So I feel a little bit better that I'm sharing that with the rest of these people who can't get bills through. So here again, the substitute, this is a substitute to Senate Bill 325. Okay, have you heard how hard it is to get something out of insurance? Anybody ever heard that? Well, okay, this bill passed out of insurance, and I am so appreciative to the chairman of that bill. This is a step therapy bill, and it sets up guidelines for our health program plans about what people ought to have to do, you know, and it sets out like 4 things. And, you know, I know medicines are expensive, and I know they're trying to keep costs under control, but if they cover a medicine and as a patient has already failed in another plan, let's say you had to change insurance plans, and you had already failed on a couple of drugs in that one, and you finally found the one that worked, what we're saying, that should be a reason for you not to have to go through a new step program and fail over and over again. If a drug is counterindicated, if your personal physician knows that taking a certain drug is going to be a problem, like one of the patients that testified, because they have a hole in their heart, something, you know, that once the doctor or the personal physician gives them all that information, that should be grounds, you know, for them not holding it up and being overridden by an appeal if they try to. Another thing is, if it's not broke, don't try to fix it. You know, if a patient's doing well, and we're talking about really serious illnesses like lupus, and it's amazing the people that come. You know, we're all sort of fond of Anna that works for the hospital association. You know, I don't know about her boss who, you know, always, you know, he got into a little trouble with Anna the last time he said something. But Anna had a problem because lupus, MS. Anna has MS. And she said I could talk about it. And her company kept denying her the test she needed to have to be diagnosed. And when they finally approved them, she was so far along that in the stages of it that she had to have a much more expensive medicine. And, you know, now it's working fine. And, of course, just last week or so, she's been going to the Shepherds, and they decided that she couldn't go back to Shepherds anymore where they can do the test and everything, you know, and she would have to go and get the blood work one time and then wait for them to come back and get it and then go again and make it because she has monthly treatments. This is a real pain for patients. And so I think this is something you could be proud of in this, and it passed out of the House and the Senate. I mean, out of the House, and I don't remember the exact vote on it, but it was overwhelmingly positive, and it's held up in the Senate. Questions from the committee? Anybody have any questions? Okay. Is there anybody in the audience that on this short notice would like to speak about the change? Okay. I'm ready for what the committee wants to do on it.
Second.
I've got a do pass and a second. Everyone in favor say aye.
Aye.
Anyone opposed? No? Okay, the ayes have it. So, and once again, I'm very thankful to the insurance And I will tell you, the insurance plans are neutral on this, as they have said and said publicly on television. There was a thing on this the other night, the insurance lobbyist. Oh, on which one? Oh, okay. All right. Okay, thank you. Thank you for the passage, and I think we can all go home, and if we can get this out of this, on through the rest of the thing, we can be proud of it and have done something for the patients of Georgia, the ones with serious illnesses. I think we need to go back to Dr. My husband practiced with a Dr. Bodie years and years ago in Woodstock, and so I keep going to call Representative Bodie, Dr. Bodie. On Representative Bodie's bill, we didn't officially make the change on the date. So can I get a movement to amend and have a substitute to House
Move
Resolution
amend.
446
446, due date 2018.
as a Scribner's error? Can I do it? Where's Betsy? Do you think we can do it? I don't know. Let's just do the amendment. It would be an amendment to HR 446, and it would be on line 64 to change December 1st to December 2000, to change December 1st, 2017 to December 1st, 2018. Any discussion? Okay,
Not parliamentary inquiry, Madam
Okay.
Chair. And I'm gonna need some help but I think our posture is we have now passed this bill,
right?
which means it would have to be sent back to us. So-
Okay.
So therefore, I would make a motion at the appropriate time that all bills passed out today minus Scribner errors.
Could be. Okay, and we're going to call it a Scribner's error because it's only changing a 7 to an 8?
Yes, ma'am, that was obviously a typo.
Okay, we got it.
I changed before I voted. There's Betsy.
Okay,
Is Betsy back? Okay.
okay.
Betsy.
Wow. You in the jungle.
I made the change before I voted.
Right, that it's really, well, I thought it wasn't until I technically signed it. Okay. Representative Peasold, did you want to say something? Okay. Okay, I mean, because I haven't signed them, but that's okay, we'll do it. Betsy, we on a House resolution forgot to change on the last line, 64, to change that 2017 to 2018. May we call that a Scribner's error? Fine.
Well, that's the question, since and I've seen this one time before, and I just want to make sure
We
you mentioned
talked
it either way.
Well, we talked about it, but we didn't officially,
Well, we officially passed it out without the amendment.
You've already passed it out.
Yes, so,
but I haven't signed the papers or anything, so it's,
Okay, then I would, if you can make a motion to retract that vote,
okay.
proper terminology or
and
not.
if you weren't here, I said just do everything minus Scribner errors
Okay.
today. Would that have been the correct procedure, just in the future,
Okay.
if we ever get it? Why not? I saw Jay Powell do it once.
Oh, well, that's the answer to it.
Yeah, right. He's an
Okay.
attorney.
Okay, can I have a motion to retract our vote on House Resolution?
So moved.
Okay.
Second.
Everyone in favor say aye.
Aye.
Any opposed, no. Okay, now can I have,
Change the date 2017 to 2018.
okay, on line 60,
64.
on line 64. We've got a motion and a second. Everybody in favor say aye.
Aye.
Anyone opposed? No. Okay, the ayes have it on the amendment. Let's go and pass the bill out again. Do I have a motion? Okay, I've got a motion and a second to move the bill as amended. It's 446. Any discussion? Okay, everybody in favor to the passage of House Bill 446 as amended, and they'll go out as a substitute. Say aye. Everyone opposed? No. The ayes have it. Good catch, Representative Reiners. Thank you very much. Okay. All right, let's see. Which ones did we do? What have we got? We've done. Okay, I've got it. Let's count. Which one's red? Okay, Senator Rhett Senate Bill 318. Okay, will you tell us the LC number that we are working on?
Yes, Madam Chair. It's LC 37265 and the letter S is in Sam. Substitute.
Okay, we're ready.
Uh,
Oh, shit. Did they add something to it? Okay, that's it. Go ahead. Center.
Thank you, Madam Chair, fellow colleagues, friends, and y'all. This bill, it looks at starting up a test pilot program where the Department of Public Health and Department of Behavioral Health and Developmental Disabilities will establish a one-year pilot program to provide for the execution of a physician's certificate for emergency examination of a person for involuntary evaluation and treatment for mental illness or alcohol or drug abuse based on consultation with an emergency medical technician or paramedic who has personally observed such person. The departments shall establish the parameters for the pilot program and seek the input of emergency medical service personnel, hospital and mental health, and addiction professionals to design the pilot program. Emergency medical services personnel shall include emergency medical technicians, cardiac technicians, paramedics, and first responders certified in the area. And the pilot program will be designed to permit such emergency medical services personnel to transport any person within the county directly to the emergency receiving facility if such emergency medical service personnel have been dispatched in response to an emergency, have probable cause for believing such a person is mentally ill and requiring involuntary treatment, or have consulted with emergency receiving facility physicians, and it is the opinion of the physician that it is in the best interest of such a person and the public that such person be transported immediately to the facility, and that such physician has confirmed that such facility has the capacity to treat the patient. We kind of discussed this before, but we worked on the substitute here and hope that is more palatable. But Madam Chair, I'm available for any questions or thoughts at this time.
Questions from the committee. I know that several people had questions last time, so you'll want to check and make sure that the changes were made you were asking about last time.
Basically, it's just a test pilot program, and we're going to have a number of people consult together, as I talked about earlier, in terms of how we should design the pilot program and move forward in order to get information on how to properly care for people who might have a mental health issue.
No motion to table.
Because as we all know, that's a big topic in the news today, and we want to make sure that just like we treat anybody else for maybe a physical injury, or that we exhibit the same sort of care and concern and for people who might have a mental condition.
Representative Newton.
Thank you, Madam Chair. Senator, I appreciate the goal of this bill. If you could, though, look with me over on line 34 and following, where it's where the EMT would consult with the emergency receiving facility physician. Is that the same facility as down in line 36 that they would be bringing the patient to, the physician who's on duty at that facility?
I believe that's correct, sir.
Right.
And is there a particular reason the goal is to sign this form prior to the patient seeing that physician? just to allow easier transport, or is there some other reason? Because typically, what typically happens is the paramedics, sometimes along with the police, bring someone in, and and that's when they get their medical screening exam, and that's when they also have a 1013 if appropriate, and if medical causes are ruled out, they have a 1013 filed after a certain amount of testing and evaluation by a licensed physician. Is there a reason you want that to happen, to be able to sign that form in the field 15 or 20 minutes before the physician sees them?
Basically, they're consulting with the physician, but they will not do anything without consulting with someone who can do that certification of a temporary 1013. But if that's the case, that they decide to go that route, but once they get to the facility, then the person who gave the temporary authorization to transport the person would have to re-examine them and decide whether or not the person should have a 1013 or maybe move them to a different facility that might can care for them.
Okay, Madam Chair, if I can follow up one question.
Right, let me ask a question about to Betsy. Betsy is, Senator, you brought this up, made me think of it. Betsy, is there anything in the law such as a temporary 1013?
Not that I'm aware of, I'm just looking that up. It's my understanding that they can't transport the patient without the physician actually seeing them. So this basically lets them transport it based on a conversation on the telephone or the radio or whatever. But I'm looking for that code section right now.
Okay, Representative, you want to go ahead and
Sure.
come
Well,
back to that?
Two things. One, the 1013s that are typically signed by emergency physicians are 72 hours. They are considered temporary holding, but 72 hours is a long time. It's more than, obviously, a regular paramedic trip. The second section that I had just a question and concern about on line 71, or I'm sorry, on line 66 and 67, where it says civil damages, I think you took out, I guess, the not liable for criminal or civil. I will tell you, I've seen in practice where hospitals have been accused of kidnapping, because essentially when you tell somebody they can't leave the room, or if you put them in a vehicle and take them. So when you took out criminal, I know that was maybe to answer a question Representative Kelly brought up on having blanket immunity. There still may need to be some consideration, because sometimes it's not just civil that are alleged when someone has been detained and they later say they were detained wrongly.
I'm open to that suggestion, sir.
Okay,
That's all.
okay. Representative Silcox.
Thank you, Madam Chair. And my question was along the same lines in terms of liability, because to me, it sounds like you're trying to give them no liability here at all, correct? Is that your intent, Senator? You want to?
Basically, from my
Or
understanding,
the, right,
I'm
the
sorry.
person. Your intent is to give the person who's transporting this person complete liability. Is that correct? Or complete immunity from liability?
Well, basically, from my limited understanding right now, if you should go to, if there's an emergency situation and EMT, emergency medical people have to transport someone to a certain place, there needs to be a certain amount of immunity involved. I think I might have used this example before, whereas let's say if somebody is unconscious or choking and they can't respond, there's some sort of implied immunity where you can render the services. And sometimes, I'm just speaking from my limited experience as a lifeguard and working in the Air Force, managing fitness, that certain things might occur, but if there wasn't any intentional intent to cause damage, but you were trying to help a person revive them or resuscitate them or get them to, if they're unconscious or need help, to a certain facility they need to go to, there probably need to be a certain amount of immunity from any incidental problems that might occur.
I guess I agree with Representative Newton that I think that you know, there are a lot of other laws that come into play if someone is involuntarily accused of mental illness and taken to a hospital. So that would be my concern.
I'm sorry, say that again. I'm sorry.
There are other legal ramifications if someone is involuntarily committed to a hospital for a mental problem. Just brings in a lot of other potential issues. So that would be.
Well, once they get them to and I thank you for your line of questions. Once they get them to the facility, they're re-examined by a person who's certified to make a decision whether or not they should remain at that facility or should they go to a different facility to treat perhaps maybe not only mental health issues, but perhaps maybe some physical issues. But it's just pretty much, that's why we put that in there.
Petrie?
Thank you, Madam Chair, and thank you, Senator. And I know I asked you quite a few questions the other day when you were here, but I just want to make sure I understand this well, because as has just been pointed out, we're talking about, I mean, I recognize the issue. I'm in community services, so I recognize the degree to which we have people with mental health issues throughout the state that need treatment, oftentimes don't get it, but we are talking about taking someone's civil rights away. And right now we have a real high standard for that with this certificate of very highly trained and educated professionals, and there's a huge disparity between there and where you would go here in this pilot. And so I have a couple of questions, but first of all, I wanted to ask you, so the Department of Public Health and DBHDD now, so you've added DBHDD in where we had DCH, and I thought that was what we needed to do, and I appreciate you doing that. So are they here today, and have they endorsed this in some way? Are they endorsing this pilot? Are they opposed to this pilot? Are they neutral? Is there, so first of all, if you could answer that, it would be helpful to me.
I'm not aware of any opposition
Okay.
to it. And this bill, the language that I put in here was part of a bill that I crafted with another senator last year that not only went through the Senate committee, but through the House committee and went up to rules. So so it's, we've been down that road before.
And if I may follow up,
Well,
Madam Chair.
let me ask if there's somebody from DBDH.
Yes, Madam Chair. This is the first, I haven't seen the new language. I'd like to take a look over it, but as an agency, we're officially neutral on it.
Okay. Okay. Representative Ryan?
I was going to follow up, Chair.
Oh,
Madam
I'm
Chair,
sorry,
if I
got
could.
another one?
Yeah,
Sorry.
finally, I want to make sure that we're all clear that this would indeed, so this pilot would allow a paramedic to fully implement a 1013, which would involuntary commit someone. Is that correct?
No, it's and thank you for your question, sir.
Yes,
They consult with the people, perhaps maybe at the community service board or whatever, and what they do is talk with them and ask them, based on what they've seen at the field, which is the best course of action. Should we take them to a facility to treat them for mental health, or should we take them to a hospital, or et cetera? But but if it comes to that point where they think that the person may exhibit certain mental attributes, then they would issue perhaps maybe a temporary one, but when they get to the facility, then at that time, they would reevaluate whether or not that person should have a full 1013, or perhaps they might tend to another
I guess what's
place.
confusing me, Senator, is that
Mhm.
right now, so paramedics are all day, every day, right now, when people have episodes like this, they are taking people for treatment. They're doing it already, and much of the time against their will. They're doing it without a 1013. They're managing people in the community who are having all kinds of episodes. And then in the hospital, these things are dealt with where you have these episodes. So I think that's where I have a disconnect. But I appreciate your answer, and thank you.
Thank you, sir.
All right. It's, okay, Senator, the board is lighting up with questions. Representative Reinders, do you want to make?
Madam Chair, I appreciate what the senator's trying to do, but you're right, the board is lighting up, I can see it. My phone is blowing up. I think in the interest of fairness and doing the right thing to the people of Georgia, at this time, I move that Senate Bill 318, the substitute to Senate Bill 318, be tabled so work can continue.
Okay, I've got a motion and a second to table the substitute to Senate Bill 318. Any discussion from the committee? Okay, what, okay. Representative Sharper. Yes, sir, sure.
Thank you, Chairman. But I think the biggest thing is really we need uniformity in what you're talking about. And just to clarify with you guys, somebody that's been doing this 27 years as a paramedic, going to these patients, we don't need a 1013 to do what we're doing. If I come to you and I determine that, okay, it may be something mental or, you know, alcohol or whatever is involved, at that time, I can, when I'm doing my report, I can tell the hospital or the crisis center, wherever we decide to go, I call in and say, look, this patient did this and maybe need a mental evaluation. I can say that. And when we get to the hospital's receiving us, and they're gonna make sure that that person is placed in a certain area, which is a regular room, but they're gonna have observation of that person. The patient is always gonna be seen by the physician, for one, to go ahead and clear the medical part and confirm that, okay, this is not necessarily the medical, that's clear, but the mental part. So they're gonna be seen, and at that point, if there's a crisis center in the area, behavioral health, they're gonna call someone out and have that person evaluated at that point. If we go to the patient and everything is clear on the medical in our crisis center, we'll call them and say, look, this is what we have. You know, can you guys accept them? They'll say, okay, everything's clear. You can come, or I call the emergency physician, say, this is what we have. We're just letting you know that everything is clear, and we're gonna be taking this patient to the crisis center instead. So there are so many different protocols and different things done across the state. One area where the deputies may not work with the paramedics, and another place where the deputies understand what the paramedics have to do. But we need some uniformity, but I think a lot of people are getting the wrong impression that we're gonna stamp a 1013 and say, okay, you're gonna go, you're gonna do that. There's things in place and protocols that give us the right to do what's best for that patient if I don't think you're in your right mind. I'm protected on that. Okay, so really I can just tell you, you're gonna, you know, encourage you to go somewhere. If you don't, then almost holding you against your will, but still don't have to have a 1013 to do that. So I just want to put that out there, that we're gonna do the best we can to get you where you need to be, but we're not just gonna do it without talking to a physician and let them know this is what we're gonna do. And if they refuse, it's up to them to be forcibly taken, you know, by law enforcement possibility, because if you're not in your right mind, I'm not gonna just leave you where you are. We're gonna take you somewhere one way or the other. So just keep that in mind. We need uniformity. So whatever we need to do in this, we need to work on something, because it needs to be uniform across the state for everybody. Thank
Okay,
you.
Representative Sharper, maybe you need to work with the senator. Okay, we have a motion to table. And a second. And Representative Sharper, you are a sharp dresser, and I want to see those cufflinks when we get through, because they are flashing as I watch you talk. Okay, everyone, you are a sharp dresser. It goes with your name. He's sharper, you know. So anyway, everybody in favor of the motion to table the substitute to Senate Bill 318, say aye. Aye. Anyone opposed, no. Okay, the ayes have it. It's tabled. Senator, if you can work on that. This is going to be my day for mistakes, and I will admit it. Can we go back to substitute to Senate Bill 325? What? It's daylight saving time. Is that what made me do it? Thank you, Representative. Now I have an excuse. Okay. It is the time when things are being added on. That was on the elder abuse bill. There's another bill writing on that. It's on the front. I forgot to mention it. So I will do whatever the committee wants to do. Let me explain the bill. Representative Dempsey had a bill that passed out of here for the pilot project on the surgeries. Her bill is being held up also. It's the exact bill that this committee passed out. If you want me to rescind our vote, previous vote, I will do it. Or if we just let it stand and you have been notified that that was also added on to it and you're happy with it. Is that okay, Bets? That's okay? Just let me know. Representative Hawkins.
I saw it, and I'm fine with it. I looked through the bill and I saw it.
No, I'm just asking if you want me to bring up and move to do anything. Betsy says it's okay for me just to notify you that that's what we voted on. Okay, like that.
We're okay.
I've had so many bills come in since this afternoon at like 1 o'clock to my office that I just missed it. It wasn't on purpose, and I don't want anybody to think ever that I'm trying to slip anything through on the committee. Okay, thank you for your confidence, committee, and to read that. And that was verbatim Representative Dempsey's bill that passed out of this committee, and it's traveling on that also. Okay, what are we up to? Okay, all right. Did Senator Unterman make it, or is she tied up? Because I will do that one.
She's still in the committee, but I just
No, it's all right. She's still in the meeting?
Yeah, but she's on her what? I sent her a note to go, come on.
Well, why don't you tell her not to? Because if we're going on to another one, she'll be here forever. Just tell her to.
I told her not to come on.
You tell her not to come, okay? All right, if you'll pull out Senate Bill 422. In the spirit of letting good policy move, instead of being held up, I'm going to move Senate Bill. Have we got it? Where is it? 422. Okay. All right, Senate Bill 422. And I have somebody from the pharmacy board here. Okay, you got somebody not from the board, but the thing, okay. All right. Okay, what this allows pharmacists to do, they would be within their scope of practice. If there is a kit that they can buy over a counter, that a person can buy over the counter to test, I guess it could be for anything, pregnancy, blood sugar, if there's something, or if it's a DNA test, the pharmacy can explain it and help the patient understand what's going on. I'll turn it over.
Sure. Thank you, Madam Chair. Thank you, committee. So what this bill does is it's a sort of a simple code update. Today, under Georgia law, pharmacists can help patients with over-the-counter tests. So these are tests that have been FDA cleared for home use. And so pharmacists can help patients do capillary blood tests, what are the equivalent of finger prick blood tests, but they can't help patients with less invasive tests, such as saliva swabs. And oftentimes patients come in, again, these are very, very simple to use and highly accurate, the simplest and the most accurate of tests, but sometimes patients do have questions. And so what this bill would allow pharmacists to do is to assist with those tests, answer questions, and facilitate them getting to a primary care practitioner with the result of the test.
Okay. Questions about the bill? Representative Peake.
Sorry, are you with the Pharmacists Association?
I'm so sorry, yes, Greg Reibold with Georgia Pharmacy
Okay, so I'm
Association.
assuming that all the pharmacists will be completely happy with this. And
That's
yeah,
correct,
okay.
yes, Representative.
Just want to be clear.
I mean, it's just letting them, people can buy them over the counter. It's just helping them do it right. It's not letting them, add more complicated tests or anything like that. Okay, Representative Price.
Thank you, Madam Chairman. So what are the limitations to the tests that can be utilized?
So the limitations are going to be dictated by the FDA. And so the FDA clears a very limited number of tests for home use. And again, they make that determination based on ease of use and based on reliability. And so if the FDA clears a test for home use, that is to say that a patient, a consumer can walk into a retail pharmacy or a store and purchase the test over the counter. That's the limitation under the proposed bill.
Can you give me an example of what tests they are?
Yeah, I mean, there's a number of tests. There are drug tests. There are saliva HIV tests is a big one. I mean, I know you've done a lot of work in connection with HIV and testing in connection with 161 and that bill. And so, for example, we know a number of patients come in and they buy the over-the-counter HIV test, and it's an oral swab test. And again, pharmacists can do the finger prick, but they can't do the oral swab. And so this bill would allow pharmacists to assist the patient and as well as facilitate education and refer to a primary care provider the results of those tests.
So currently, they're allowed to buy it. So why, if they're allowed to buy it, what
Pharmacists
what does
are
this do?
allowed, it's kind of a weird, kind of a quirk in the law that this is cleaning up, but patients can walk in and purchase the tests. But if they go to the they can purchase it at the pharmacy, but if they ask the pharmacist to help, pharmacists can only help if it's a finger prick test. And, technology is evolving, so we're seeing more and more tests like the saliva test, hair follicle test. And so this would allow pharmacists to assist with those as well as the finger prick tests.
And is this a step to billing for that activity?
Billing is typically done like under, for example, Medicare Part B. Pharmacists can't bill for those type of tests, and I'm not aware that there's over-the-counter tests that can be billed to a payer. Conceivably, the law allows pharmacists to bill for pharmacy services, so they could have a fee associated with it if they were so inclined.
So this would not this would allow and not prohibit billing for these tests?
I mean, the bill doesn't speak to billing. I'm not aware of any pharmacies pharmacists that bill for the finger prick tests. Again, it's something that they sell and that they would be assisting the patient with.
Thank you.
Okay. Representative Henson.
Thank you. I guess I'm a little confused about the saliva tests.
Yeah.
So right now, the pharmacist cannot help a patient with that.
That's correct. They can sell them, but when patients ask for help, and again, they are easy to use, but some folks just aren't comfortable. And so if they ask the pharmacist for help, the pharmacists are sort of in a weird spot because their hands are tied.
Does this allow them to do it with the saliva test?
It would, yes. Anything that's ultimately been cleared for home use for patients, it would allow pharmacists to assist with.
Now, here's the other question I have. We really don't have a DNA over-the-counter test, do we?
I believe there are DNA over-the-counter tests, but those aren't testing for disease states. And so, again, this bill contemplates testing for disease states and drug use.
Okay, thank you.
Okay, Representative Petrie.
Thank you, Madam Chair. Yes, sir, just want to make sure I understand this full well. Right now, our pharmacist can help with over-the-counter tests as long as they're capillary blood tests.
Yes, Representative.
We've circumscribed it to that. This would open that up to saliva or any other type of over-the-counter tests that are available.
That's correct, yes, Representative.
And at any rate, none of this is billable. No one is billing now for helping people to interpret capillary blood tests.
Yeah, not to my knowledge.
Not to your knowledge. So basically, we're just allowing our pharmacists. We talk a lot about access to care and how oftentimes we don't have that. This is allowing our pharmacists to do more of what they do well. My understanding is, I don't want to hurt my friend right here's feelings, my understanding is our pharmacists are probably the most popular, most highly respected, some of the most highly respected healthcare providers in our community. So even more so than doctors sometimes. But at any rate, so it sounds to me like this makes immense sense. And
yeah, thank you
for your comments.
Thank you.
Everybody likes to beat up on their doctors except their doctor, and they love them. Right.
They're legislators.
You love it, right. Are there legislators? Yeah, okay. Representative Hawkins.
Oh, yeah, I just had a question about liability. There's no problem with liability in this?
No, I mean, so essentially, pharmacists, just like any other healthcare, provider, have insurances for those things, and the bulk of their liability comes from filling prescriptions.
For the pharmacist.
Yep.
I mean, this is a common sense piece of legislation.
Thank you, Representative.
Okay. What? Representative Hatchett. You've got it. It's
do pass.
I think
Second.
we have a motion for due pass second. Is there any further discussion? Yes. Okay. Representative Price?
I feel that in line 13, just saying tests is overly broad and that we have not limited it to the type of tests that could be performed or assisted with, and also, as the gentleman stated, to bill for. And, you know, I had a pharmacist come and ask me about that last summer, and it was clear the intention is to, you know, practice a type of medicine, you know, surrounding these tests.
So I guess I would make 2 points. One is this is the Clinical Laboratory Act. This isn't the Medical Practice Act. So I don't think that it would be to practice medicine. 2 is if you look at the bill on lines 16, it's tests that are available to and for use by the public without licensure of the user of the test. And so that's the narrowing language that would basically limit it to, again, only tests that have been approved by the FDA, cleared for home use.
And interpreting.
I'm sorry?
On line 14, it says interpreting.
Yeah, well, again, the tests themselves have been cleared, and so they would be able to assist the patient with interpreting those results, which again are the most simple. That's why they've been cleared for home use by the FDA.
Okay, all right, we're at the posture of a vote. Everyone in favor of the passage of Senate Bill 422, say aye. Anyone opposed, no? Okay, the ayes have it. Thank you very much.
Thank you, Madam Chair and
Okay,
Committee.
and I will be carrying the bill, and so I'll send the stuff on for it. Thank you. All right, okay. Okay. House, let's call Representative Brass and, Senator Brass, sorry, Senator, I didn't mean to demote you. Thank you for the promotion. Yeah, right. It's much more interesting on our side. A lot more people to make it more interesting than over there.
Yes, Madam Chair.
So this, if we're going to have the substitute Senate Bill 31, this is LC 337429S. I'm sure y'all have been hearing over the past session the chatter on the hall. So Senator Brass asked me if he could bring this, and I said, well, we'll listen today. Today's a hearing. We will be meeting again tomorrow for whatever comes up at the last meeting. So today's a hearing, so it's the time to get your questions asked. Go ahead.
Thank you, Madam Chair. And I would like to start off by saying I am not on the Insurance Committee in the Senate. So please
Are you on the
everyone
Health
keep an
Committee?
open mind. Or the Health Committee.
Mm.
I'm on neither.
Okay.
So I can help you in other areas, but not those. But no, I come today with substitute to Senate Bill 31. As you stated, Madam Chair, it's LC 337429S. And basically, we all know that we live in the #1 state to do business. We've been that for 5 years. And in my district, I've got a tax-paying company that's paid almost $250 million in salaries since opening its doors in 2012. They've completed almost $200 million in capital investments, and they've booked almost 100,000 flights at a cost of over $41 million. They've booked about 223,000 plus hotel rooms at a cost of $18.7 million. And this company is Cancer Treatment Centers of America. They've made a total economic impact, and this is construction, equipment, and 4 years of operation back when this study was done, of $1.7 billion to the state of Georgia. They've created 14,517 jobs, and almost 1,200 of those are direct jobs. Their estimated state and local tax revenues resulting from this project are over $73 million. And now they're wanting to grow their business. And again, here in the #1 state to do business, we're telling them no. And we're telling them no by way of certificate of need. And not only are we telling them no, they cannot grow, but only 35% of their patients can come from this state, the state which they reside. So Section 2 and 3 of this bill addresses that. What we're doing is eliminating the definition of destination cancer hospital. And the idea here is we are removing them from statute, putting them in the CON process just like every other hospital. We will eliminate the cap of 50 beds, which they are capped at by statute. And if they want to grow from that 50 beds, which they are currently at, they will be allowed to go through the CON process just like every other facility in Georgia. And then also, this bill will eliminate the penalties and everything that's associated with that 65% of the patients have to come from out of the state. So that's kind of section 3. 2 and 3 really addresses all that. So, and the second part of this bill is addresses another problem, a bigger problem we have, and that's in rural Georgia. You know, we all understand that quality health care in rural Georgia is struggling. And in order to find a solution, we've got to correctly identify what the actual problem is. And, you know, we're told that hospitals like CTCA are part of the problem. And this problem is what I call rural patient migration. This is where our insured patients are leaving rural Georgia and they're going to Atlanta for various reasons. And that's because they don't have the facilities, they don't have the doctors, they can't get the care they need at home. So again, you know, CTCA, are they part of the problem? Yeah, they are. In the last year that we have data for, if you look at hospitals that fall under the Rural Hospital Stabilization Program and hospitals that fall under the Rural Tax Credit, from the counties that those hospitals reside, CTCA took 63 patients in 1 year. In that same year, we had just looking at 3 hospitals inside of 285, just 3 of them took over 4,000 in that same year. So I want you to think about those numbers, 4,000 plus compared to 63. So again, that rural patient migration is what's costing these rural hospitals to really struggle. So Section 4, what we've done in the bill is that cancer treatment centers will provide 5% of its adjusted gross revenue to indigent and charity patients. They're still going to provide care to Medicaid patients, but what they're going to do that no one else has ever done before is they're going to add 1% of their adjusted gross revenue or $1 million, whichever number is less, for the next 5 years will go into the Indigent Trust Fund, which will go to rural Georgia hospitals. Now, is $1 million going to save rural Georgia? No. But it's my hope that this bill creates a blueprint that we can build that fund up to $20, $30 million, that where medical facilities that are needing to grow, they have a way to navigate through the certificate of need process, and in return, they're going to infuse money into our rural Georgia hospitals. And this money will allow those hospitals to spend money on staff and better facilities so they can keep more of their patients at home. And again, it's my hope that as more facilities want to grow and expand, they will participate in what we've created here, and that's the Rural Hospital Infusion Plan. And that can revive quality health care outside of Atlanta. With that, Madam Chair, I'll be happy to take questions.
Okay, I'm sure my board's going to light up.
I'm sure it will.
But I would like to say one thing, making no comment one way or the other in the bill, but I do appreciate the fact that they were willing to do $1 million for 5 years. I will tell you, when Grady Hospital was on the verge of closing, my CEO at Wellstar, and it's a different one than we have today, we discussed how desperate the situation had become from Grady. And as I think this committee knows, Grady trains half of our physicians, almost half of our physicians. If the hospital had closed, we would have lost all of those residencies. And even if somebody had opened it up again, those residencies would have been gone. And they have the majority of our residencies in the state. And it's just one of the quirky rules of the feds, is that, you know, once a hospital closes, the residency slots are gone, somebody else buys them out, they don't get them. And I asked my CEO, he was on his way the next couple of days, to go to where the CEOs of the big hospital in Atlanta. met in a private type meeting, and I asked him, I said, could y'all not, there was a $6 million need right about that time. And I said, could each of y'all maybe just do a little less advertising and kick in $1 million each to help us save our safety net hospital? I mean, I said, just think of what Wellstar will be like, the South Cobb Hospital, if Grady closes. I mean, just think about it. He went, he made the proposal, he called me. They couldn't agree on it. Nobody was willing to put forth to help save Grady, our safety net hospital. So I think that in itself is a very generous offer, and certainly one that I think is great. I've never heard it from any other hospital. And regardless of what happens on the bill, I appreciate the fact that somebody knows that even though it won't solve all the problems, sometimes $1 million or other hospitals getting to help, the big ones helping other hospitals in trouble, are really very important. So thank you for that.
Yes, ma'am.
Representative Peake, you're on.
Thank you, Madam Chair. Senator Brass,
Yes.
just a couple of quick questions if I can. Is it not true that in addition to the $1 million that is being committed to the fund, that in the bill, line 91 through 94, that you're going to increase the amount that's going to be going to the Indigent Care Fund? Is that not true?
That is true.
And that also some of the complaints that we have been hearing from folks, or folks are against this, that CTCA only takes insurance patients, that you're including on line 95, that you will provide services specifically to Medicaid patients. Is that not true?
That is true.
Is it not true also that if we pass this, which I am in full support of, that patients, citizens in our state who are in the most vulnerable part of their life, suffering from cancer, looking to make tough decisions about their care, will now have the option to be able to choose CTC if they want to. They're not going to be forced to go there. They're not going to be made to go there. They may decide to go to somewhere else in Atlanta or something. But at least now they will have a choice as a result of the passage of this bill. Is that not correct?
That is correct, but you know, let's be honest. They have choices now. I'm not going to deny that fact, but here's the fact. My district leads this state in patients denied to Cancer Treatment Centers of America. People can't go to, they have option, they don't have an option in their home county. They have one option. I'm trying to offer people 2 options in one county, and they continue to be denied, and again, leading the state where this thing sits in the heart of my district, to me, just does not make sense whatsoever.
Senator, if I may, I mean, I'll challenge you on that. I mean, there are people all over the state that are being denied.
Well, no, I agree.
In my county, and I know it affects you directly,
Yes.
but people all over the state are being told, well, sorry, your number, 36%, and so therefore you cannot be allowed and given the option to go to CTCA because of this archaic restriction.
Right, and they do have options, and they are choosing to wanting to go to Cancer Treatment Centers of America, and yet we're telling them no. So you're exactly right.
Well, I'm grateful for you bringing this. I look forward to wholeheartedly supporting this measure too.
Thank you.
Thank you, Madam Chair.
Representative Peasall.
Thank you, Madam Chair. Senator, I've got a question on lines 20 and 21. Any facility granted a CON prior to June 30, 2018. Just thinking ahead, if we're looking out 10, 20 years from now, and another competitor wants to join the market, will they be then held to the standard that CTCA is held to currently today?
Well, if someone new wants to come right now, they're not going to be able to come.
They
I
can't
mean,
come.
that's CTCA came here. I mean, through the line 16 through 20, that was the only way they could come, and that is through statute and to be defined as a destination hospital, destination cancer hospital. And so that's what we're trying to do is eliminate that, take them out of statute, put them in the CON process just like every other medical facility in the state of Georgia.
So if someone else did come in, they would have to go through the same process that CTCA went through?
Based on recent history, their CON would be denied.
Representative Peasel, I was on that committee. In fact, I chaired the part in the House. They would have to have a special legislative bill passed specifying that that specific hospital, the way it stands now, could come into our state to do what they want to do.
I see. Yeah, that,
Like if
that
it was
predates me by a little bit.
In fact, what happened was, while we were doing this, or right before we did it, the orthopedic hospital the orthopedic group in Columbus that's so famous, bought a hospital, couldn't open up an orthopedic hospital in our state, and
So
they went across the river into Alabama and bought a hospital
And they're doing very well.
and opened it up. And so, because we didn't have a way to let them know, so it would take a special bill by the legislature to let them. It doesn't even fall under CON as it stands today.
Thank you, Madam Chair.
And I'm clarifying that just because I went through that battle. Okay, Representative Bennett.
Thank you, Madam Chair. Thank you, Senator, for bringing this. I have a disclosure. I have a special interest in CTCA, but I have two questions.
Yes, ma'am.
Particularly on line 91, where we talk about uncompensated indigent and charity care, which meets or exceeds 5%. And then right up under that, it says provide services to Medicaid patients. Are you currently providing services for Medicaid patients and indigent care? And if so, is there a percentage related to that?
They are currently, I don't have the percentages. I know there are people in the audience that could probably speak to the specifics, but with it being a hearing only, I'll do whatever you want, Madam Chair.
Madam, my second
Do we
point-
have somebody that can answer that? I know they are providing, I just don't know the amount. If you'll identify yourself, answer that question for us.
Thank you, Madam Chair. I'm Ray Williams with CTCA. I appreciate the question. Yes, we are providing indigent and charity care. The statute stipulates that we have to provide at least 3% every year that we've been in operation. We've exceeded that 3%, and in fact, this last year that we reported, we were at 4.6%. We are also seeing Medicaid patients. We've never turned away a Medicaid patient. Admittedly, we were about 2 years in getting into the Medicaid system. You all are familiar that prior to a couple of years ago, there was not a centralized credentialing process for Medicaid, so it took a while to get our physicians in the hospital credentialed. Since that time, though, our numbers have increased year over year on the Medicaid recipients that we've seen.
Do you have an idea of what the Medicaid?
Yes, ma'am, I do. We've grown from 3 Medicaid patients in 14, 20, and 15, 82 in 16, 108 in 17, and already this year we're at 87 Medicaid recipients. And that's considering also that, as you all know, 75% of the Medicaid population are pregnant women and children. And we're an adult hospital, so that percentage of the population is not eligible to come see us. And then there are other elements within the age, blind, and disabled population that also are children and on waiver programs. So we are seeing every Medicaid patient that comes in the door. We are contracted with 2 of the CMOs and are seeking contracts with the other 2 CMOs as well.
Okay. All right, I just had a question about how long did it take you to get the Medicaid number from CMS or wherever it comes from?
We opened in middle of 12, and it took us until pretty much the middle of 14 to secure all of the licensing and credentials that we needed to see Medicaid patients.
Okay, because that can be a lengthy process.
Yes,
you can
ma'am.
see. And are the Medicaid patients, I'll go back, Representative Bennett, I'm sorry, if they're from Georgia, then they take up part of that 35%?
Yes, ma'am.
Okay, so it's not on the outside? So
Correct.
Would most of your patients have to be on Medicaid then to?
No, ma'am.
Okay, all right. Representative Bennett, I'm sorry.
The 3 and 4, the indigent and the medic, the 86 patients that you mentioned.
Yes, ma'am.
What percentage is that though? Is it 1%, 2%, 0.5?
I'm sorry, the Medicaid
Yeah,
population?
you mentioned a number of 86.
It's probably less than 1% of our total patient population, probably, probably less than 1% of the Georgians that we see.
Okay, thank you.
But a lot of that would be because our Medicaid basically covers mostly women and children,
Yes, ma'am.
not other adults.
Right, that's correct.
Okay. Representative Lott.
Thank you, Madam Chair. Senator Brax?
Either or.
I would like if you could clarify something that you said, and I was trying to write the notes down, but 4,000 patients, and correct me if I'm wrong, that have been seen inside of the 285 belt from the rural counties.
Mm-hmm.
They're coming in, but Cancer Treatment Center had only seen 63. I'm not sure what year or what time period that was.
It was for calendar year 2015, which is the last year we have data for.
And so we have no way of limiting anything that goes on with all of these other hospitals that have had certificate of need. So patients have the choice to come in, and they do. They're just getting stopped at the CTCA like them all, right? They've got that 35% that they can use. No, if they are not able to be accepted as a patient there, then what you're seeing is then they're moving their way into Atlanta anyway. They're coming this way.
I really, the data doesn't say one way or the other on that, but I wouldn't think they'd be going back home in most cases. But logic would say that, but I don't like to assume.
I mean, all those patients weren't, all of that 4,000 didn't try to be seen at CTCA.
No, and
No,
just to
that's
be,
just that they're choosing to go to Atlanta hospitals.
and to be clear, that number is, I mean, on all kinds of illnesses, not specific to cancer.
Representative Price.
Thank you, Madam Chair. I was curious on line 97, or 6 rather. Do we know what the adjusted gross revenues were for any given recent year?
It will be, I'm sure they do. I don't have those numbers.
I'm just curious because we've been throwing around the figure 10 million. I'm wondering if that's the
You
real
don't have
number,
it, right?
or what the 1% would be of really, because it's lesser of.
It's right. They would be paying the $1 million every year.
Okay.
If that answers your question.
Yes, thank you.
Representative Hawkins.
Unless cancer is cured.
Well, there are new drugs company. We're going to hear about really tremendously
That'd be
wonderful
great.
drugs. And of course, I know that Representative Peake encourages it, but I thought maybe he had something that would thought it would cure it pretty soon. I would picking on him about everything that he thinks it can do. We're going to hopefully get the government to let us study and find out if that really happens or not. I'm picking on him. He's leaving, so I can't let him go without picking on him, Ben. Sorry. Oh, please. Can we get back on subject? Okay. Representative Hawkins.
Yeah, help me understand something here, because I guess I've gotten lost in this process. Your hospitals are accepting federal funds through Medicaid, correct?
That's my
For those.
understanding, yes.
So, my understanding is the Impala Act says that if you accept federal funding, then you cannot deny access of patients to a hospital. Is that correct?
I think that would be, well, it would definitely be in the emergency situations. It doesn't talk about long-term care. It's
okay.
emergency situations.
Well, I
And then-
believe
You
right.
don't have an emergency room, do you?
No,
No,
sir.
it's not that
They're
kind of-
willing to do that.
Right, so you sort of escape the Impala Act from that aspect.
Again, they're
How
willing to do
about our other
that.
hospitals? Do they escape that? Does Grady get to escape that? They
I would
don't,
think
do they?
not.
So that sort of carves you out right there quite a bit, doesn't it?
Well, I think that, Representative Hawkins, they came in under a different,
I know.
as a specialty hospital, that would be like, if we had made the orthopedic hospital that went over to Alabama to open, we made them have an emergency room. I guess you could just have an emergency room for orthopedics, or I know that other times there's been other people that wanted to do maybe a mother-baby specialty hospital, and you'd make everybody have an emergency room.
I understand. I guess where I'm also going is that we let them come in as a specialty hospital under certain parameters, and now we're going to remove those parameters.
Well, I mean, is anything in this world stationary and never going to change? And I know that the hospitals have come to me, and I have opened up CON at least once for them. I mean, I'm not trying to pick it, but when do things ever, I mean, don't we come back and change laws and bills as things grow? I mean, it's a little hard to anticipate. I guess it's hard to anticipate how many Georgia people would like to be treated at cancer treatment centers of the hospital.
Well, Madam Chair, I'll add too, if I may. When I presented this bill in the Senate, I was offered a hearing only, and only a hearing only. I took it.
Gotcha.
Just try. Well, and
I understand.
Okay, I know. Check me and see if I'm right. I mean, are you not landlocked into the number of possible beds? I mean, I think they wanted to add 50 beds. Is there not
the
a
cap
restriction
right now
to-
in statute is 50 beds, and that's what this part of this bill does is remove that cap. But it's still, in order to grow, they will still go under the proper CON process, just like everyone else.
It's a few. I mean, not 17. I think I had it for 16. Northside bought and either in 15 or 16, they bought the cancer doctors. I think they now have more cancer doctors across our state than any other group. At that time, I heard that in 1 year's time, they had 25,000 new cancer patients in a year. 25,000. Ray, how many can Cancer Treatment Centers of America treat? Probably in a year.
Well,
How many did you have?
Yeah, we're averaging probably about 2,500 to 3,000 patients a year. And on the bed issue, we are running about 75 to 80% capacity on the 50 beds that we have. And that's pretty full when it comes to beds. We are landlocked. We do have additional land on the property. But what we would like is the opportunity to have the possibility to grow the beds. Under the current statute, we don't have any possibility to grow the beds. We'd like to be able to go to DCH, and if we can demonstrate the bed capacity for a period of time like other hospitals, have the opportunity to grow those beds to meet that need that we have.
So you're not asking to be accepted, I mean, removed from, to not have to meet the CON's rules for need,
No, ma'am. In fact,
just to be included in that?
we're putting ourselves,
like-
we're recommending in this bill that we put ourselves under the CON process. And in fact, we're giving up a couple of special exemptions that exist for a destination cancer hospital in order to do this, in order so that Georgians don't have to be denied access. If CTCA is the place that they feel like they prayed about it, they thought about it, they talked about it, this is the best place for them, then state law shouldn't stand in the way of their access to that hospital.
And I mentioned Northside, that's one hospital. That doesn't include the Winship, wonderful thing that they have at Emory, what they have at Wellstar, and I think they're trying to get the designation of a cancer, center of excellence. I think it's on cancer. It doesn't count all of the patients that are going to them, so I don't really see that 2,500, or even if it grew to be 3,500, they're not a big threat to, as far as taking patients from anybody, I don't believe. And, hopefully, these new medicines that are coming out, they'll end up being able to cure it, and we'll just shut down all the cancer centers that are around the state at some point in the future. That would be the most wonderful thing to happen. Senator Henson.
My question's been answered. Thank you.
Senator, sorry, I
Gladys.
elevated you, Representative Henson, Representative Newton.
Thank you, Madam Chair. On page 3, just the 91 through 95, I appreciate that commitment on the Indigent Care Trust Fund of $1 million a year plus the services to Medicaid. Do you know on lines 91 through 94, when that 5%, you increased it from 3 to 5, do you know if that's related based on the charges that would have gone to that charity patient or the average revenue or Medicare rates, or how is that calculated? Do you know?
I don't know the answer to that.
I didn't know if that's,
Okay,
could be a big difference.
if you'll come forward and identify yourself. I hadn't seen you in a long time. It's been peaceful.
It's nice to be seen.
I'm teasing.
It's nice to be seen, though, so
Yeah,
thank
nice
you.
to see you
Thank
again.
Thank you, appreciate it. I'm Victor Moldovan. I represent CTCA. I do a lot of their legal work in Georgia. So the way, if you look at the statute, the way we've defined adjusted gross revenue is the way it's defined by the DCH today. And it's defined as total charges, less contractual adjustments for Medicare, Medicaid, and then less bad debt. So you take a percentage of that number is what, then that's the formula used not just for CTCA in the statute, but for everybody, all hospitals, all other providers. That's the same formula. So we've just put the exact same formula in the statute.
All right. So does that mean that, so if a patient has a $10,000 charge for their cancer treatment, but their the average revenue was $3,000 and Medicare would pay $2,000, do you use one of those three numbers?
It's all based on charges.
Okay,
that's the way it's always been. I'm not sure why, but yeah, it's charges.
I appreciate you going up on it to 5%.
Sure, thank you. Yes, sir.
Okay. All right, that's all of the questions. Anybody else on the committee want to chime in? No? Okay, we have Tim Keebler. Tim? Yes, today. We'll be meeting again tomorrow and decide what we want to do. I mean, there'll be other stuff going, probably by then. They seem to keep bringing stuff to my office at the last minute, so my secretary went ahead and assistant, she here? She told me, there she is, Lynn, who's been driven crazy. Lynn told me she found rooms for us next Monday, Wednesday, and what? And Wednesday are the days that we're in, just in case we needed them. So we've got a room reserved, so just hang tight and watch your emails in case we have to meet. Okay, go ahead, Tim, I'm sorry.
No, ma'am, I'm glad to wait as long as you'd like me to. My name is Tim Kibler. I'm with the Georgia Alliance of Community Hospitals. We're an 85 hospital or association representing Georgia's not-for-profit hospitals. Most of our members do deliver oncology care to Georgians at all income levels, and several also deliver care to all ages of cancer patients as well. We very much oppose this legislation. When CTCA came to Georgia, they were, as the chair lady referenced, were given a special exemption under the law to allow them to open up and operate under the circumstances they're operating now. In fact, the bed number and the out-of-state patient population requirement both came from CTCA. This is not something that was imposed upon them by a nefarious legislature. This is what they asked for, and they said it's consistent with what they do in other states. Our membership is very concerned that to allow their paying patients to be cherry-picked and brought over to one institution would harm their ability to serve their entire communities. And in fact, I think you'll find that Georgia's, while I don't speak for them, I think you'll find that Georgia's medical community is a big part of the reason that the numbers that Senator Brass shared with you are correct, that 4,000 some patients came from the rural tax credit areas up to metropolitan area hospitals. 63 went to CTCA because physicians generally do not refer their patients to CTCA. They send them to institutions like Northside, like Emory, like Piedmont, like St. Joe's Candler, like AU, these institutions that have been serving Georgia patients for many, many years and will continue to do so without regard to the patient's ability to pay. I think in deference to the fact that it's late, and you've heard a lot about this already, and this is a hearing only, I'll stop my statement there, but welcome any questions that the committee may have.
Okay, you're gonna get some from me, and you know I'm very fond of you.
Yes, ma'am, as I am of you.
Thank you. But I want to clarify something. There were 5 of us that sat in the governor's conference room, 5 of us, who ended up making decisions about what went in this bill. And the only way we could let this hospital come in, because of the hard work and the 80-something lobbyists hired by the hospitals, and it was that number because they hired everybody they could get their hands on, the only way we could do it was for the 5 of us fighting among ourselves, was to put the 35-65 restriction on. And it wasn't something that the cancer treatment centers or the hospitals liked. It was something we said, this is, you take it or you leave it. So let me make that perfectly clear, because I was in those meetings, and it was the only way that we could come to an agreement, and the 5 of us were in there trying to come to a compromise on it. The other thing is, if the hospitals are taking patients and hurting small hospitals, why have you not been here through your group with a bill that would limit the number of patients that we can take in the metro area? Because there's certainly a difference between just under 70 and 4,000 and something. I think you're hard put, and those 70 people come from all over the state, outside the metro area, because I've seen the figures, because that's my job to look at them when they come tell me something. I want to see the figures. And it's one person from this county and one person from this county. And we have 159 counties, so there's some of those counties they're not coming from. But compared to 400 and something thousand people, if you're worried about us taking them from rural Georgia, then, and you know what it is, Tim, people have choice. You know, I'm pretty sure if I lived in Ocilla, Georgia, and I don't even know whether Ocilla, Georgia has a hospital or
Ben
not.
Hill. Yes,
Huh?
ma'am. Ben Hill.
Okay. And my doctor down there told me that I had cancer.
Oh, I'm sorry, Irwin County.
Okay. I would be on my road either to the metro area or cancer treatment. I mean, I'm not saying which one I would go to. Because I would think that perhaps there would be people up there that were better specialists that dealt with my kind of cancer day in and day out than perhaps my doctor and my local doctor that I liked, who maybe saw the type of cancer I had, you know, once a year if it was a special kind of cancer or not. But people have choice, and because I'm a Georgian, I can choose to go where I want to. I will also say that there is I have never seen such animosity toward another healthcare facility as I have seen against cancer treatment centers. You would think that they have horns and a tail. And it's my understanding that they are not even allowed to join the hospital association, that the animosity is so great that they're not allowed to join the hospital association. And so to your answer of why doctors don't refer, many of our doctors at the Winship Center work for Emory Hospital, and they refer within their thing. WellStar doctors work for WellStar, and those doctors refer to WellStar. That is a lot of the reasons that people, and Piedmont has its cancer treatment centers. So it's not necessarily that what Cancer Treatment Centers of America does is substandard in any way. It just means that we've got these big systems that are locking in the patients, and and to a great deal referring within their own systems. Now, when physicians did that, you know, they got in trouble with antitrust laws. But now hospitals can do it. So I just take real exception with you on those three issues. And I have been through the thing on that, on those CON changes, when, not you, Tim, but one of the people that works at small hospitals sent out a skull and a crossbones several times, a big poster of it, across this state, saying that if any of those changes that happened to CON, that the hospitals were closing. And we were protecting the small hospitals because the people that made those decisions, like myself, care about what happens to our small hospitals. And I'll give you an example. That thing went out. If we let general surgeons become a specialty area that could open up L&Rs, that the small hospitals were going to close. We have so few general surgeons, and it would take 4 of them when they were to be paid to even make a L&R feasible at that time because of what they get and pay for less than hospitals. Then we only had at that time something like about 35 counties in this state that had 4 general surgeons, and they probably, not all of them would have ever gotten together and worked on an L&R, and those were in the more metro areas, but yet the skull and crossbone and misinformation went out that if we let them have that designation, they were going to close small hospitals. So I'm not just taking it out on you, but I am tired of misinformation about lots of bills going out. Now, I'll fight you to the tooth on truth. But let's keep it the truth, and there are 2 sides to it, and I was in that fight. I still have the scars from the lies that were told about me by the people lobbying against the changes to that CON. But I decided, to count myself lucky, because at least I didn't have to, like Florida, send my husband and my dogs out of town and have a personal bodyguard. And that's what happened to the person doing leading the CON fight in Florida. So let's just get it straight, and if you're going to bring something up, I'm going to counter it with the truth as being the person that was in that. So, not picking on you, you just got it first. So, thank you. Anybody else want to ask any other questions? No, go ahead. Okay, Representative Peak, you want to ask him a question?
Madam Chair, I'm always glad to be before you, and I certainly welcome your thoughts and perspective.
You
You're
bring
a very
me how
knowledgeable
they really
person.
you bring me how they really hurt you and your small hospitals, and I'll say it to this group just like this, but you have to prove to me that they're really going to hurt you.
Yes, ma'am.
Okay.
I would like to say that the reason that I believe the 6535 came from CTCA was because the chief operating officer named David Kent was in a meeting with Representative Hatchett, myself, and representatives of the Georgia Hospital Association. And he is the one that told me then that the number 6535, that idea was theirs and came from them. So I repeated what he had shared with me. I believe it to be true. I'd never heard the story that you just told about the 5 people in the governor's office. But I certainly would not have known. There's no reason I could anticipate or understand for him to have been misleading us in that conversation.
Because he wasn't in there with us, and I understand that, Tim, and thank you for telling me that. And I will say, as the negotiations went on, and it was first brought up that we had to limit Georgia's, of course we went back and said, what can you live with? So in that essence, it was, okay, if we do this to you, what can you live with? Just as we would do other hospitals. So it was sort of halfway in there between the truth. But the decision was us on how much, they could tolerate and how much we could get through.
Yes, ma'am.
So thank you for telling me the other part. And,
If I may clarify that I did not mean to think that small hospitals were being denied the opportunity to provide oncology services to the people in their community. I think it's the physicians in those communities that are referring people up to the metro areas hospitals, as you said. And Emory's not a member of mine, so I can, if I'm bragging on them, I'm telling you what I believe.
Emory's wonderful, Wellstar's, all these hospitals have different.
Those are some of the oncologists that I think any of us would want to treat our loved ones were they ill. And they have really a cutting-edge treatment center not too far from here, as you well know.
I'm closer to you. Good. I'm glad they're doing that. I'm glad the hospital's reaching out. I haven't had cancer. I'm very fortunate.
Hope you never get it.
I mean, you both. I can't imagine it, but I want the choice to go where I want to go. That might be Mayo. It might be somewhere in Massachusetts. It's one of their great, wonderful ones. It might be Mount Sinai. And, I want that choice. And I think when you have something that serious, you ought to have a choice to be able to go wherever you want to go. And I just have problems with us limiting, especially Georgians. I mean, it'd almost been better if we, except that it was a destination hospital that you fly to get to. It'd been better to say people from out of the state have to be limited, and we take Georgians instead.
But I'm sure you'll recall that medical tourism was a big selling point for bringing it to Georgia in the first place.
Well, and I tell you, I'd rather, having gone, and you weren't here probably, when my first year, my wonderful little secretary came down with a very aggressive form of breast cancer. She was a single mom. I was in a wonderful suite over here. There were 8 of us. We raised them. It was not working. She went, my second session, she went almost every day for radiation. She was in her mid-30s. It wasn't working, and she wanted to go to Mexico. Okay? We raised the money for her, Natalie, to go to Mexico. And at the last minute, she got scared, and all the others decided since I didn't have children, I could go with her. And I'm telling you, they had a hotel where people from all over the country came right outside. You go across the border. And we went across the border on the bus, and I thought, oh, my God, I can't let her stay here. I mean, we are not getting treatment here. And then they went into a residential area, and I watched the nurses do things in there and their techniques and stuff. And she got treatment there. I was able to come home after a week. She stayed longer. It didn't work. It wouldn't have been my choice, but I would much rather her have gone to Cancer Treatment Centers of America, an American destination hospital, than to have gone to Mexico. No matter that it was at least very clean and everything watched, and I could let her stay and not worry that something bad was going to happen to her. I would have much rather us had a destination hospital like we have that met American standards. So, yeah, people do still travel all over, and I really worry about people going to Singapore and all these other places that they're going to get medical treatment. I worry what's going to happen to them if they have complications and they're over there in a foreign hospital. I would rather our people stay within our states and within our hospitals, and that's just my humble opinion. And
yes, I would very much urge them to go to Winship or to Wellstar or to
yeah,
Piedmont.
good
or
boy,
to
stay
Northside.
on point. Okay, I think that, okay, Representative Fry.
Thank you, Madam Chair. And thank you, Senator, for bringing this up. I recently lost an uncle to cancer, and this is something that's near and dear to my heart.
Sorry to hear that.
For Tim?
Yes.
Okay, good.
And really, I just want to get a general picture of we got the 5% increasing the indigent care to that. How does that relate to the existing indigent care percentage of other hospitals? Like, and I speak to Piedmont, which may not be you, but that's used to be Athens Regional. I think they do a ton of indigent care at a loss of like 25 to 30 million a year. Last I checked a couple years ago. Now, what's the percentages in general related to that stuff?
Well, state law requires the 3% for charity care, but I think you will find, and I don't have the numbers in front of me, I don't have the numbers in front of me, but my expectation is that you would find institutions like Athens Regional will have done a good bit more than 6% in indigent care, and they would have done significantly more in Medicaid as well. And it hasn't really been discussed in the context of today's hearing, but there's also a much greater Medicare population that is treated at the oncology centers outside CTCA. As you all know, the most likely people in your family to get cancer are the older folks. And cancer disproportionately strikes folks over 65, and their patient population does not reflect that. For instance, in Savannah, I was talking to them recently in St. Joe's Candler. I think they have 61% of their oncology population is Medicare. I think at Athens Regional, it's like 51 or 52% of their patient population is Medicare. Grady is much higher than that. Others, generally speaking, the hospitals that are part of our association are in excess of 50% of their oncology patients are Medicare patients.
Okay, but you're talking about Medicare patients.
Yes, ma'am.
We're not talking about that's what they pay on. They pay on Medicaid.
Right.
Their percentage. So you're talking about Medicare with the
ma'am.
seniors being in the federal government does pay better than a lot. Sometimes I think some of the insurance companies on the treatment of.
Well,
For
it's my understanding they pay faster. than
Oh,
the
at least they
insurance
pay.
companies.
Thank goodness on something that they pay faster than the.
Follow-up, Madam Chair?
I mean, because that's a problem. Let's work on getting the insurance companies to pay the smaller hospitals and not drag it out and make
Hallelujah.
them on their thing, right?
That's why I'm so fond of you, Madam Chair, is that you would advocate for
let's call
the
it what it
insurance
is.
companies paying more rapidly. That would be wonderful.
Go ahead.
Thank you, ma'am. And just to clarify that, when you say in the legislation it says Medicaid, now why would you bring up Medicare? Maybe the senator can answer that question. Are they not required, or do they not take any Medicare patients?
Oh, no, they take Medicare patients. Their Medicare patient population, though, is very small compared to the other oncology services in Georgia. The point was that it's the overwhelming majority of their patients are commercially insured patients that Shirley just referenced. The overwhelming majority of the patients in the other oncology services in our state are not. They're Medicaid, Medicare, or indigent.
One more for the senator, please, ma'am. So, in your area, you were talking about that this is located, and I know they're real happy that you're battling for them, and I can appreciate that. Is there another hospital nearby?
There's one within about a 2-mile radius, Piedmont Noonan.
And would they be the ones that would be competing? Do they do like cancer treatments over there as well?
They do cancer as well.
Would there be you said that they would, CTCA would be looking to open an ER. Does that have to go through the CON process?
It does not.
Okay.
They're willing to do it, but I would imagine their neighbors aren't going to want them to do that.
Sure, and I'm just looking
And
at
I'm
a
not
level
speaking
playing
for
field.
them.
You know
Right.
what I'm
Representative
saying?
Right.
Fry,
I'm just trying to learn about it.
you
Thank
know,
ma'am.
the hospitals complain that they see all these patients that can't pay. I've heard it over and over for years, that they can't, that, the emergency room people come in and they don't pay and all this kind of stuff. But at times when we've discussed trying to find other ways to handle those patients, they go, no. So there's a dichotomy there. Where, they say they cost them a lot of money, but when we try to find some way, maybe to where they have less of that, they don't want us to mess with their emergency room patients. I mean, because one thing you think about it, the emergency rooms feed into the other hospital. I mean, not totally, but there is a feed. There are things to it, and I'm just telling you, how it has been. I also will tell you that for years, Piedmont Hospital didn't pay their 3%. Okay, they didn't have indigent patients, and it wasn't until they started buying up other hospitals that they started having this population, and yet we let them function and all. I mean, it was just the way it was, because they didn't have a lot of people that met that standard that went to Piedmont Hospital. I mean, but sometimes there's good to be here long enough that you have some institutional knowledge of how this went down. So, okay, Representative Bennett.
Quick question, Madam Chair. Thank you for giving me another opportunity. But I don't want to miss this opportunity to get this one little piece of information. what percentage, you may or may not know, but CTCA question, what percentage of their patient population is Medicare? We talk about Medicaid, but I'd like to know Medicare answer.
Okay.
Thank you for the question. Our total Medicaid, Medicare population is about 20% of our patients. And the numbers have increased year over year to the point we had 1,408 Medicaid patients in 2017, a total of about 3,500 Medicare patients over the year. And if I can, I will have the opportunity with the mic just to talk a little bit about partnerships. You know, it was mentioned that hospitals don't partner with us, the physicians don't partner with us. Let me just mention a special relationship we have with Wellstar. We have a thoracic surgeon at Wellstar that works with us, that partners with us. And in fact, we've had over 150 surgeries that have been done at Wellstar in partnership with that particular physician.
Okay, great. Are you listening, Brandon? I am so glad and so proud of my hospital for doing something in conjunction with them. Thank you very much. I've picked on Wellstar a lot lately. So would you go back and tell Candace I said thank you for being that partnership? Okay.
But to be clear, Wellstar does not support this legislation.
I know that, Tim. All these dichotomies, I mean, really.
Madam Chair, can I answer the question just a little bit further? To your question, particularly, one of the ways we can measure indigent and charity care, because all the other hospitals are seeing other disease types and other types of patients. They're seeing children. All we see is cancer. So one of the ways to measure that is through radiation therapy. That's a service that's provided for oncology patients. We provide it there. And between 2013 and 2015, Athens Regional provided 1.04% indigent charity care. We were at over 3.5% indigent and charity care, just to give you some perspective for that radiation treatment. But that's really the closest measure that we can get on oncology services.
Okay. Any other questions for Tim? Okay. Representative Howard, you've got a question for Tim?
No, just, I'm not sure who can answer this. Let me just put it out here. It's not many of us that were here when we voted on the legislation to allow CTCA to come to Georgia. And I was just beginning, so it was in the early stages of my tenure. And I remember there was a big fight over letting them come in. And the contract for them to be here was 35% of the Georgia patients, they wasn't worried about Georgia patients, or concerned, should I say, about Georgia patients as much as the out-of-state or out-of-country patients that they would take in. And, you know, that was the part that got most of us during that period to support their being in Georgia. And I guess my question is, I don't want to feel like I was shammed.
No.
Or now that we have a lot of new legislators here, now we're going to change the contract or redo the contract. And I guess my question is, what caused the desire to change the contract? I guess should I say?
I can answer it for you.
What caused it? Because it was all built on. We're not concerned. We don't need Georgia patients to survive. And that was the way it was said to us. That was the way I remember hearing it. It's the out-of-country, out-of-state patients that will keep us going. And that's what I remember.
And I think that's the way they thought. They had been such a destination hospital in other places. As I've talked to them over the past years, they were very surprised, and Ray, you can tell me if I'm wrong on this, they were surprised at the number of Georgia patients that wanted this as an option. You know, they still get a large number coming from the East Coast, but Georgians have stepped up and just said, we want to be able to go there too, at a much larger rate than they ever anticipated. They really didn't anticipate the demand.
So is that, I don't know how that works for marketing and, soliciting patients, but I see the advertisements all across the state,
Just like Wellstar
Yeah,
and
just-
Piedmont
right,
and all
yeah.
the other ones?
Right, yeah, and so do they do that in other states? Do they do that in other parts of the country? Or are
Ask
they
Ray.
really going after Georgia patients?
No, sir, I appreciate the question. We operate in 5 total states. And in each state, we have a marketing program, just like every other hospital does today, have marketing programs. I think when the 65-35 came up, and you're exactly right on how it happened. I wasn't here at the time, but that was kind of the percentage that we saw in the other states, was 65 out of state, 35 in state. Madam Chair is correct. What we didn't anticipate was the demand in Georgia for a specialty cancer hospital. There is a need, clearly, for that. And what's happened over the years are the unintended consequences of those percentages. For example, in 2016, we had 70 patients that we had to turn away simply because this ratio was there, who wanted to come to CTCA, wanted their care, their treatment there, but they were forced to be turned away by this arbitrary number that ends on December 31st and starts again on January 1st. So that's the unintended consequence that has led us to come back to say, you know what, these are the patients that want to come here, they want to be treated there. The law should not prohibit that. And let me give you a great example. Had a lady in Milledgeville area who unfortunately was diagnosed with inflammatory breast cancer in this fall. She wanted to come to the hospital, but unfortunately we couldn't see her because of the ratio. She started treating at another hospital. Our oncology specialist there has treated over 400 patients with inflammatory breast cancer. She went to a hospital, saw an oncologist who had seen 1 patient with inflammatory breast cancer. So she was devastated when she had to go to this other hospital. Now, fortunately, after January 1, we were able to get her in because of this arbitrary number. But she had to endure that for that period of time until we could get her into the hospital. That's what's wrong with this law, is it's arbitrary and it should be changed. And in fact, we've done the polling. 77% of the people in the state agree that the law should be changed even though there was a deal made prior to this. 93% of the people in the state agree that if you have cancer, you should have the right to go wherever you want to go. 89% believe that hospitals should not be limited on the number of Georgians they could see for cancer care. That's why we want to change this law.
So even after, question, follow up, Madam Chair. So even if the number, say if this law were to be changed now, and you get to a number that you cannot serve over your hospital can't serve the number of calls that you are receiving, do you refer those people to Emory or to Piedmont, or are you saying that no, they can't do the same service that you do, or is this because patient care becomes the issue?
Sure, and
patient care is the issue now.
Yeah, patient care is exactly the issue, sir. And that is why if the patient wants to come to CTCA, they may not have that opportunity to do that. If they want to go to Emory, Piedmont, Wellstar, Northside, all quality hospitals, all with quality oncologists that are taking care of people every day. We applaud them for that. They have the ability to do that. I appreciate the question about referrals. Because when we reach our capacity, we have to have, under the current law, we have to have a deferment agreement with another hospital. Strangely enough, we couldn't get Piedmont which is 2 miles away, to agree to take our patients. So we have to send them all the way to DeKalb County, to DeKalb Medical Center, when we're at capacity. So we would love to have partnerships like we have with Wellstar and other hospitals that we could work together on those patients. As a matter of fact, we're working with an FQHC in Ocilla on an indigent charity care patient to work with them on treating that patient. That's the type of relationship we'd like to be able to have in the state with the other hospitals and other providers. So to ensure that patient care is the #1 priority.
Thank you.
Okay. Representative Hilton, is this for, we have other people that want to testify. Is this for the presenter or for Tim?
For the author and the presenter.
Okay, good. Go ahead.
Thank you, Madam Chair. Thanks to the author for bringing this bill. As you know, I'm for choice, whether it's in education or healthcare.
I'll see you Monday.
This either goes to the author or the presenters. Are you aware of any other industry or business in Georgia where we arbitrarily cap Georgians' access to those products or services?
Representative, I am not, but again, as the chairlady said, this was a very special circumstance for them to come into Georgia. They could have gone through the Georgia certificate of need process to come in and would not have needed the special legislation, but their business model didn't fit the CON requirements. So they elected not to do that, so they came to the legislature and asked for this special opportunity under the law.
Well, Tim, they elected not to do it because they didn't fit, and it would have been an immediate turn down. So it would have been ridiculous for them to spend the time going through CON when there was we have no place in CON that deals with specialty hospitals. It was new and different.
It's my understanding that a large part of that concern was because of the out-of-state patient population that they intended to have.
That was okay, we were concerned?
Yes, ma'am. That the medical tourism component that was inherent in the original intent in bringing them into the state would have meant that they were not going to be able to serve a region in the way that is required under the certificate of need process.
Okay, I think they just weren't eligible to apply through it, but okay.
Madam Chair, may I answer the question
Yeah.
specifically?
Yes, sir.
Thank
Yeah.
you for the question. Again, we operate in 4 other states. In no state are we restricted in this manner. And in fact, in the other states in which we operate, we do exactly what we're proposing through the committee substitute to operate as a general hospital that specializes in cancer care. There are no restrictions. I've done a lot of research on it, and maybe GHA or the Alliance have other answers, but I can't find another hospital in the country that has a limitation on the number of in-state patients that it can see simply because of a statute that says you can't see more than that percentage.
And frankly, I couldn't think of any other industry and or business that we treat that way.
Can you clarify something?
Charter
Because my vice
schools,
chair
a little
said
bit.
that at the time this went through, he was in the Senate, and they were told that Tulsa had a restriction on it. Can you find that out for me?
I will check on that, but to my knowledge, that's not true.
We were told that.
For the hospitals. Okay, Representative Henson, is this for the Tim or for the speaker, the presenter? Oh, I guess you don't have your light on.
I do have my light on.
Who's the question for?
Not sure.
Oh, okay.
2 things. I think I just want to say something. When we talk about any other industry that doesn't treat things this way, there's no other industry that has someone else dictating the amount of money that they're going to accept for a particular product. And we have insurance companies that dictate how much money is going to be paid for a particular project in any kind of health care. Do have a question with regard to CTCA. When all hospitals advertise, they're usually very positive advertising. And I have no idea the amount of income is spent on it. But CTCA went out and did a lot of negative advertising. And that we can't get in, we can't do this, we can't do that. So I had people calling me and constituents, I can't get cancer care, or treatment for cancer in Georgia. was the misinterpretation that was coming forth. And I just felt that was misleading. And just wonder how much money was spent on the negative advertising.
So certainly it wasn't our intent to be misleading in the advertising. I don't have a number exactly how much was spent. The intent of the advertising campaign was to make the public aware that this limitation existed in the law. And I think the survey results that I quoted reflect where the general population and the general public is on the issue. They don't want a limit on where they can get their cancer care, because the law in fact does limit that under certain circumstances. And so that was the intent, was to make them aware of that. And certainly you all as legislators are the only ones that can change that. So that's why the messaging was the way it was.
Okay, thank you both.
Representative Henson, it has been a couple of years since I saw the numbers, but as of, I think, 2015, over half the oncology service advertising in the country was CTCA's advertising. Every other service provider in the country made up less than 50% of the total advertising. I don't know what they spent in Georgia. It's been obviously quite a lot.
If I may, I'm sorry, I don't want to do this back and forth, but I think what Mr. Kibler is representing is the overall advertising campaigns for CTCA. Again, we're the only hospital system that has 5 hospitals around the state, so I would expect those numbers to be significant. I'd also say that CTCA was a bit of a trendsetter and with marketing in the healthcare field. Certainly everyone else has caught up to us and in fact has mirrored a lot of the same things that we have done on our regular marketing campaign. That is not necessarily what your question was about, was specifically to this piece of this legislation and this issue.
Well, and Representative Henson, I'll add too, you mentioned it was negative. Well, that means the law is negative, because all those ads did was tell the truth.
Dave, can I answer? Sure. I feel that a lot of people just didn't understand at all the negative advertising. I mean, first of all, I had to explain what CTCA was to them and explain that we didn't ask to create that. We were asked to create it, but we didn't ask them to create it. So there was a
debatable.
difference. It wasn't a matter of we imposed something absolutely terrible on them. We didn't. You know, they wanted to come into Georgia. And there
we
was a
gave them
deal that
one
was
option.
cut, and I'm not getting into whether it should be changed or not, because I'm not going there. But I'm just commenting about the
Representative
negative.
Henson, we did impose it on them.
But
We
they came
did.
to us and
Well, they
asked for
came
it.
and wanting to come, but we don't do that. We don't impose that to other companies. This was an unusual thing. We imposed it on them. They had no choice if they wanted to come in. They had to take it or leave it.
Okay.
And it was the legislature that did impose it on them. So we are responsible. You know, in the end, no matter how much we're lobbied, one way or the other, the 5 of us sat down there and decided that we would impose that on them and put it to the House and the Senate. And so the legislature at that time imposed it. It is our doing that imposed that on them, because that was the only way they could do it. Okay, I'm just
No, thank you.
I'm just telling you how it was. Thanks, Tim. You've been in the hot seat long enough. So let's put Ethan there. Come on, Ethan. How do you want to go about this now? And you weren't here, were you, when this went down?
I was. It was
Were you
my
here?
first full year with GHA.
First
It was
what?
first
Ooh,
full
baptism
year.
by fire.
And we're still here talking about it too. Madam Chair, if it pleases the committee, I don't know if you want us maybe at the table. I'd like to have Carrie Conley, our Associate General Counsel, up here with me.
Okay.
Or we can just stand.
Whichever way you want.
If you want it, I'll give it up for you, Ethan.
Thank you, my friend. I think it might just be a little easier.
Yeah. Whatever's there, we can go at you either way. Carrie, we'll leave you alone. We'll just pick on him.
Let me know.
Yeah, we'll just pick on him.
Madam Chair. Thank you so much, and members of the committee. I'm Ethan James with the Georgia Hospital Association, and I apologize that you don't have Anna up here with you today. We represent more than 170 hospitals throughout the state of Georgia, from our small rural critical access hospitals up through our multi-hospital urban health systems. We also represent the 53 other cancer centers, cancer hospitals throughout the state, where all patients have choice. All patients. We don't have to worry about, the percentages. They treat Medicare, they treat Medicaid, uninsured. They don't ask. They don't put advertisements on their website about maybe we don't take your form of insurance. We have these laws, the federal laws that say we have to treat everybody. Come to us. Even if the federal government were to change that EMTALA law, it is still our mission to take care of all patients and communities. And that EMTALA law is not going away, by the way. It's going to be here. And we're still going to be here taking care of all patients. And the Georgia Hospital Association is going to be here in front of you dealing with all issues. We're going to talk about the mental health issues that we were talking about earlier today in committee. We're going to talk about the nursing shortages issues that you bring up, and you're concerned about nurses and doctors and access to care. We're going to talk about the opioid crisis. CTCA is going to come back to you every year for more CON restriction, doing away with more CON restrictions on them.
I mean, I don't think you can
I mean,
speak for
they
them
do
and
it. They do it every year. Every year, they got their nose under the tent back in 2008 with this law that they did bring. They agreed to it. They brought it. It was their idea. Let's do it this way.
Okay,
And-
Ethan,
and
you're
every
now
year.
arguing with me. It was
No,
not.
I'm talking truth. I'm presenting facts, Madam Chair.
They agreed to it because it was the only way we get it through, but we imposed it on them because that was the only way that the five of us could come to any kind of an agreement.
Mm-hmm. And Madam Chair, you used an interesting phrase that I kind of caught back there about take it and leave it. They took it and then they left it because they don't live up to this agreement one bit. And I'm here to tell you, one of your colleagues who does not sit on this committee, but one of your House colleagues recently asked the State Department that regulates this, do they live up? A very simple question. Do they live up to this agreement? Do they live up to their 3% indigent charity care?
And-
Do they live up to their 65% out-of-state rule? Very, very simply.
And
that
I
State
also,
Department-
okay, and I also asked as chairman of this committee if they did. And if you want to know how it happened, and I don't know that it's been totally decided, they followed what DCH told them to do. You know, if a department tells you what to do and how to file something, I think that's the way you do it. And the department admitted to me that they had done that.
The department and also state law also says that they have to file their annual patient discharge data with the state. They do not do that.
Okay, well,
It is not verifiable, and the department actually responded to your House colleague by saying, we can't answer this very simple, straightforward question. And they've actually elevated this to the Attorney General to weigh in on it.
Right, and it's probably
because
the
it's
reason.
not simple, and it is hide the ball, argue it, don't submit what the law requires them to submit. So now they come here asking for a new deal, everything they want. Do away with the out-of-state percentage. Do away with the bed cap. Do away with the 3%. By the way, the rest of Georgia hospitals, on average, not some of the ones that do 25, 30% indigent Medicare, Medicaid, some of them over 50% indigent Medicare, Medicaid. The rest of Georgia hospitals average close to 8%.
Okay, Ethan, the
across
reason
the
they
board.
can't answer that, and I'm probably in trouble with them for even saying anything, and the reason they couldn't answer my letter either is because of the position in DCH and what had happened with what went on before and what they had allowed to happen had to go to the Attorney General to see how they're going to handle it and their liability.
Yes.
All right.
If they would
not
just
their, not CTCA's liability, but the department's liability.
and if CTCA had just followed the more simple law of submitting their patient discharge data, which they still do not do, maybe it would be verifiable by CTCA.
I don't know that. We can
by
ask
DCH.
Andrew about that.
Ethan, if I could for just a minute, in the Carrie Conley with the Georgia Hospital Association, for those of you that don't know me, we've not surprisingly done a number of Open Records Act requests along these lines over the years, trying to get information from the department. on what CTCA is and is not filing. And all of the formulas that they're using that don't correspond with the requirements that are in the statutes that you put in place for them have been CTCA's ideas. It's not something that's coming to the department where the department is interpreting your rules and saying, this is the way we feel like it should be calculated. They're all coming from CTCA saying, we
This is the
feel
way we
like we
like- we
should
would
be
like
able
to
to
do it.
calculate it this way.
It's not what the department tells them to do. It's, hey, this is the way we'd like to do it. Is that okay? Well, now it's up to the Attorney General to decide. And I guess when the Attorney General's office rules on that decision, maybe they'll look at some of the fines that CTCA should probably have to use. I mean, wow, they're offering $1 million a year for 5 years, $5 million? Well, by my calculation, I think they owe about $28 million in fines.
Well, okay, so
Current.
basically what you're doing and what you're saying, both of you, is you're saying that our department is incompetent.
No, ma'am.
No, yes,
ma'am.
you are.
No,
Wait a
ma'am.
minute. Wait a minute. Wait just a minute. If you're saying that some entity, which could be one of your hospitals also, goes to our Department of DCH and says, oh, I would like to do my stuff this way, and then the department just says, oh, well, then they can do it that way.
No, ma'am.
Our department has the right to say you can do something or you can't do something. And no matter if it came from them and said, is this a way we should calculate it, or we think it should be calculated this way, which hospitals and other people ask the department stuff like that all the time on all sorts of issues, if we're doing it the right way, then our department has the right to say at the time, no, you can't do it that way. That is their responsibility. And if they didn't do that, it's not CTCA's responsibility. It's our department's responsibility for not telling them, no, they can't do it. So if you're saying they got away with it and our department didn't respond, then you are saying our department acted incompetently and was at great fault for letting this occur.
Madam Chair, for the record, I am absolutely not saying DCH is incompetent.
Well, and in fact, the state sent a notice in January to CTCA via their lawyer telling them that they were not in compliance
Because
with their
y'all were
indigent
questioning
charity
it.
care requirements.
No, ma'am. No, ma'am.
Well,
Madam Chair, I don't want to be redundant with a lot of the excellent
good.
points
Go
that
on with the other stuff.
the other points that
Yeah, get the rest of it out.
Tim Kibler did with the Alliance. He did a great job expressing some of our concerns about this. But if I could maybe answer some of the other questions and concerns that came from the committee. Representative Hilton, you asked about these types of restrictions being placed on other industries. I think the healthcare industry is so unique because no other industry requires members of that industry, businesses within that industry, to give away their care for free, to give away their product, their business for free, which is what the federal law, the MTAL law, does require. Treat anybody, regardless of ability to pay, who walks through your doors. We have to do it. We have the Medicare and Medicaid program that, as Representative Henson was saying, by contract, they underpay us. And think about this. Hospitals and other Medicare and Medicaid providers are the only government contractors. We're government, we contract with the government to provide health care services for these populations that the government insures. We're the only government contractors that are paid less than cost. The Defense Department, you got Lockheed Martin over there in Marietta, they get cost plus a profit. Road builders, the people who build our roads and our highways and our bridges, the 85 bridge collapse, that the folks that came in there and did that, they got cost and profit. Our government contract says you're going to get 85 cents on the dollar for Medicaid and about 95 cents on the dollar for Medicare. Less than cost. So to say, does this happen in other industries? Well, maybe, maybe not, but our industry is very unique. And it is not a free market. When you'll hear some of these other folks up here talking about free market and level the playing field, it is not a free market in healthcare. We have to give away our business.
Ethan?
It is not leveling the playing field. They're playing a different game. We treat these patients 24/7, 365. All comers, they get to select who they're going to treat. And it's not about inpatient, outpatient. It's about which patients are insured. which patients have the lowest acuity. They're going to turn them away for a variety of reasons. And maybe the answer that day is because they've hit some threshold that, by the way, is absolutely not arbitrary. It was selected on purpose. It's not arbitrary. And it was not unintended consequences. These were the intended consequences, that they would only treat 35% from Georgia so that they wouldn't have the impact, the adverse impact, which is what CON law speaks to. They wouldn't have the adverse impact on the 52 other cancer hospitals in Georgia where all of these patients, all of the patients, Medicare, Medicaid, uninsured, all of them have choice, real choice.
Okay, now you're getting my dandruff up, okay? First of all, Impala doesn't say that you have to treat everybody for everything. It is said emergencies. Hospitals have taken that to mean, because they're scared of freaking lawsuits, that they and the legal, the trial lawyers, that you have to treat them in non-emergency situation. But the Impala law says in emergency situations. The other thing, if the hospitals, you do get paid less through Medicaid and Medicaid, but the hospitals are eligible for the Indigent Trust Fund. Now, maybe it doesn't make you totally whole, but it comes up pretty close to it. I don't believe CTCEA is eligible for the Indigent Trust Fund money.
The disproportionate share
The
hospital.
disproportionate share
You have to be a birthing-
hospitals,
You have to be a
right.
birthing hospital.
Okay, right, that's what I'm saying. And those are federal funds, and hospitals have been able to take care of them. And I'm really tired of hearing how poor hospitals are because they treat everybody, when Wellstar, I think, paid cash for the new hospital in Paulding. Not cash, but they paid for it. Community bonds, okay. And we have new hospitals going up. If you are strapped for funds and you are about to go under, you don't go build a brand new hospital. And Wellstar's not the only one that built a brand new star. One of the ones that I like a lot up in Northeast Georgia Medical Center built a brand new, and that may be the one that paid cash for it. The hospitals are not hurting like they want to say that they are. And as I said, things change for you. You've asked for changes. You've wanted other changes, but you're so scared of opening up the CON law that you won't even open it up for things that would help you, even when I've opened up before and said, I will only open it up for you, and unless I come with you, to you, and you okay it, I won't let anything else go on it. But you're so afraid of this one little hospital over in Noonan that you won't even do things that would help y'all. That's pretty bad. And while we're on it, you tell me what rationale you have for not letting them join a hospital. They are a hospital in this state treating Georgia patients. Why can't they belong to the Hospital Association?
Madam Chair, I believe my members, my 170 plus members throughout the state, get to make that choice. And we do not have a category for a destination cancer center.
Well, it'd be
They're not a hospital. They're a destination cancer center. And we're not going to change to allow them to join.
Okay, well, if my committee doesn't understand how irrational the feelings are about Cancer Treatment Centers of America after that statement, I don't know how we'd have to knock them in the head to understand I have just never seen anything like it.
Madam Chair, we're not afraid of this, but I tell you, this is not even a CON bill, and it's getting opened up for CTCA. So any old CON bill, you don't think they'd jump on that? Or the other people that only want to take advantage of it and cherry pick their patients? Yes, we are concerned about that.
What I'm saying to you is I have it opened up before and gave you my word, and it was fine to do that when it was to your advantage, or your hospital's advantages. And I didn't let anything else go on it. And I have offered to do that again to try to help the hospitals when there would be something that would be to your advantage. And you've been so scared that, even with my word to let the bill die before I would let anything be added to it, you wouldn't move to help your hospitals because of the irrational fear of Cancer Treatment Centers of America. Now, that is a plain fact.
No, ma'am, we are not afraid of that. We've seen how these bills change. This is not even a CON bill, and it's getting changed.
Go on.
Madam Chair, I want to get back to what you said about EMTALA for a second, because you're absolutely right. EMTALA applies in emergency situations. And what it requires is that if you have an emergency department, you have to screen and stabilize a patient to make sure, to determine whether or not they have an emergency. And if they do have an emergency situation, you have to treat that patient until they're stabilized. But what we don't talk about a lot with EMTALA is that that is how those patients that are uninsured or on Medicaid get to the hospitals. And so part of the reason that specialty care providers like CTCA, but also like ambulatory surgery centers, don't see as many uninsured patients is because they're not coming to them because they don't have an emergency department, which is part of how the Certificate of Need program does help to level the field, because those patients are coming to us, yes, through the emergency department, and yes, once they're stabilized, we don't have an obligation to treat them, but we continue to because they're already there. And then they've already accessed our services. And so from the patient's perspective, it doesn't make sense at that point for them to change providers, even if they do have that opportunity. So while you're absolutely right, it's only in emergency situations, it is one of the main ways that especially the lower income patients that don't have good insurance get into the system.
Right, and I'm thinking that our hospitals do that, but you do get paid, and there is also the fund that comes from the feds to help y'all make up that fund. And I also know that at times, because we've had the records when we've discussed this before, that the hospital turns over to determine how much money they get from those funds, not the discounted rates, but if they send you a $10,000 bill, that's what, and it's not paid, that's an indigent person, then that has happened, and we have seen the figures, that $10,000 is turned in as being what you lost, not what you would have gotten from an insurer or somebody like that, but the exaggerated cost way above what the actual cost was.
And you're right in terms of what's getting reported to the state is charges on the state forms, but when we do the calculations as to the percentage of our costs that are getting recouped on Medicare and Medicaid patients, those calculations we are doing based on costs, not on charges. And even with the additional disproportionate share hospital funds, we're not getting to 100%.
And in fact, it's $1.7 billion annually that hospitals lose on indigent charity care, Medicare and Medicaid shortfalls.
Fine. And
$1.7 billion, which I thought was interesting that earlier they mentioned the economic impact since CTCA has been open is $1.7 billion. That's what we lose per year.
Well, how many hospitals did you say you had?
170. But that's an interesting figure. $1.7 billion a year. That's nothing to just like cast off as, oh, you're not going broke. We had 9 hospitals close in the last 6 years. 9 hospitals. We can go back and look in the early 2000s and the 1990s and 1980s, all the different hospitals. It's more and more. Every decade, more and more closed. The 1990s, I think it was 21, and most of them were freestanding psychiatric hospitals.
Well,
those hospitals close.
And why would
and the
that be?
Patients don't go away. We don't lose those patients that were going to those hospitals. They continue to go to the other hospitals. And we see the domino effect as those patients that are uninsured and Medicare and Medicaid patients then go to the other hospitals and put a deeper burden on them. And then some of those close. And Georgia is growing, and we're losing more and more money each year treating uninsured Medicare and Medicaid patients. That is the fact.
Well, let's go to the closure of the hospitals, because I'm on the rural council and with a couple of other people. And it is not just because of CT or CT that they have the influence of what's causing rural hospitals to close.
So
a lot of times the rural hospitals close because they have really bad management. They also close because people are moving out of the counties and they can't, and it is happening all over the country in states that were big for farming. If you get a map, there are maps of the U.S., it will show you people are moving away from the country into the suburbs. That is just a fact. It is what's happened. It happened in the Industrial Revolution. People quit farming. They moved into the cities. There was mass trouble in the cities, in our big industrial centers when they were overflowed with people. And we are having a great deal of the same thing in our areas today. There is a whole lot of factors that go into why we are having problems with rural hospitals.
You are absolutely correct,
And
and that does not mean that we need to sit here and ignore something else that could impact those hospitals. Yes, we are going to oppose this. We vehemently oppose this bill.
Right. Well, that was a given. And this won't be the first time the two of us have ever gone at it like this either.
I
But
know.
let's just get it out in the public, because I'm telling you, there are two sides to every story. And I've never seen the irrationality that I've ever seen before, and the false stories that go out about it.
This is not false. These are facts,
It's-
Madam Chair.
It's just like saying, you know, they're going to ask for more and more and more. You cannot know.
Well, we said that back in 2008, and sure enough, it came true.
10 years later,
No, it started back in 2013.
here again.
They were open one quarter when they were coming back here seeking more changes.
And things, you know. Okay, you have anything else to say? I like
Yes.
Gary.
Thank you, Madam Chair. I do want to, we talked a little bit about indigent charity care, and Ethan mentioned it briefly in his remarks about their commitment to indigent charity care. And what the statute requires is that they provide 3% of their total adjusted gross revenue. And there was a question asked earlier about what that was, and we haven't had an answer to that yet. But according to what they filed with the department, it's over $905 million for 2016 in adjusted gross revenue. So 3% of that is required by law to be provided to Georgia residents. Now, the number that they provided you, the 4 point something, was all of their indigent patients, regardless of whether they were in Georgia or not. And so when you look at the indigent and charity care that was provided to Georgia residents in 2016 and in prior years, they have not met that 3% requirement. And you're right, the department has not called them on it until this year. And so the penalties that they have removed from themselves in this bill are in order to get themselves out of that potential trouble. And they come to you with this generous offer of paying in $1 million a year to the Indigent Charity Care Trust Fund for 5 years. So they're going to pay $5 million into the Indigent Charity Care Trust Fund. Well, had they been subject to the penalties under the existing law, it would be much, much, much more than that into the Indigent Charity Care Trust Fund. Tens of millions of dollars more than that.
I don't believe anything in the law as it written is retroactive.
No,
That would
the-
take away the department's ability to collect that or whatever was necessary. And Andrew, can you get me the stats on all the hospitals to see if they're all paying everything and put it in form where I can understand it by tomorrow, please? So, I mean, let's just look at everybody and see their gross, and if they're paying in the amount of money. You had a vacation last weekend. You were in New York. You could just spend the night here. I mean,
Sorry, Andrew.
and also, will you tell the commissioner? Thank you. It really isn't. So we don't want our companies moving there. Come up here, please.
We do, our hospital survey, financial survey information is available to the public online. I'm not telling you to go get it there.
You don't.
I'm a little bit smarter than that. But I will see what we can do. We are talking about a specific requirement here that's different than a broader requirement.
Okay, a synopsis of if other people, I mean,
I'll follow up with you after the committee to
Okay.
find out exactly what you're looking for.
okay. You want to go at it anymore? I like you
Sure.
much better when I talk about your daughter's chickens. Okay. What? What does she do? What's that? Okay, we have
Madam-
one question, and I'm gonna
I
let
was gonna say,
Yeah, Madam
sounds
Chair,
like
in the
they don't
interest
have
of
any
time.
questions for us.
Representative Hilton in this.
Chair,
Yes.
may we go home?
Yes, we are adjourned.
Time.